Hello everyone, welcome back. In today's video, we will simplify and explain the inotropic effect, how the heart increases or decreases its force of contraction, and why it's clinically so important. We will cover the mechanisms, positive and negative inotropic agents, and their role in heart failure, shock, and more. So let's get started. Let's start with the basics. What exactly is inotropic effect? The term inotropic comes from Greek. Ino means fiber and tropic meaning to influence. So the inotropic effect simply refers to any change in the contractile force of the heart muscle. We divide this effect into two main types: a positive inotropic effect, which increases the force of myocardial contraction, and a negative inotropic effect, which decreases it. This effect is primarily centered on the myocardium, especially the ventricular myocyte, which are responsible for generating the pressure needed to pump the blood throughout the body. Understanding inotropy is critical in many clinical conditions. For instance, in heart failure, positive inotropic agents can improve cardiac output. In cardiogenic shock, they help maintain tissue perfusion. And in cases of hypertension or certain arrhythmias, drugs like negative inotropic effects may be helpful to reduce the cardiac workload. And remember, the inotropic effect is different from chronotropic effect, which alters the heart rate, and dromotropic effect, which affects the speed of conduction through the heart's electrical system. Inotropy is all about how strong the heart contracts, not how fast signals travel. Now that we know what the inotropic effect is, let's understand how it happens. The cellular mechanism behind changes in cardiac contractility. So, the main factor that controls the strength of each heartbeat is the amount of calcium inside the cardiac muscle cell during systole. That's the contraction phase of the heartbeat. Here is what happens step by step. In step 1, it starts with an action potential depolarizing the membrane of cardiac cell. In second step, this opens voltage gated L-type calcium channels, also known as slow calcium channels, located on the cell membrane. Third, calcium enters from extracellular fluid into the cytoplasm. Fourth, this small calcium influx then triggers the release of much larger amount of calcium from the sarcoplasmic reticulum through structures called ryanodine receptors. This process is called calcium induced calcium release, or CICR. Now, fifth step. As calcium floods the cytoplasm, it binds to troponin C on the thin filament. This shifts tropomyosin, exposing actin binding sites, allowing the cross bridge cycle to begin, which results in muscle contraction. And in sixth step, the more calcium that's available, the more cross bridges can form, and the stronger the contraction, a positive inotropic effect. Now, when contraction ends, calcium must be removed from the cytoplasm to allow relaxation. This process is called lucitrophy. Calcium is pumped back into the sarcoplasmic reticulum by the SERCA pump, or sarcoplasmic reticulum calcium pump. And some calcium is removed from the cell by the sodium calcium exchanger. Certain factors enhance this calcium cycling, increasing contractility. For example, beta adrenergic stimulation increases cyclic AMP, which activates protein kinase A. Now, this protein kinase A enhances both calcium entry and calcium release from the sarcoplasmic reticulum. Another example is digoxin, comes from digitalis, which blocks the sodium potassium ATPase, increasing intracellular sodium. This reduces calcium removal by the sodium calcium exchanger, leading to more calcium inside the cell and a stronger contraction. So, at the cellular level, inotropy is all about calcium. How much enters, how much is released, and how efficiently it's handled during each heartbeat. Now, let's discuss the positive inotropic agents. These are the drugs that increase the force of contraction of the heart muscle, making each heart stronger or each heartbeat stronger. They are most commonly used in conditions like heart failure, especially acute decompensation, cardiogenic shock, or other states of reduced cardiac output where heart need helping pumping more effectively. So there are several major classes of positive inotropes. First is sympathomimetic agents. This includes dobutamine, dopamine, epinephrine or norepinephrine. They work by stimulating beta adrenergic receptors, which increases cyclic AMP levels, resulting in greater calcium entry and release from the sarcoplasmic reticulum. They act fast and wear off quickly, useful in the emergencies and ICU settings. Second, the cardiac glycosides. The classic drug here is digoxin. It works differently by inhibiting the sodium potassium ATPase pump. It increases intracellular sodium. This reduces the activity of sodium calcium exchanger. So, more calcium stays inside the cell, enhancing contraction. Digoxin has a slower onset but a longer duration of action. Third, phosphodiesterase 3 inhibitors or PDE3 inhibitors. Examples are milrinone and inamrinone. So these drugs block the enzyme PDE3, which normally breaks down the cyclic AMP. By increasing cyclic AMP levels, they improve calcium handling and increase the contractility. They also cause vasodilation, earning them the nickname inodilators. Fourth is calcium sensitizer, a newer class with levosimendan as the prime example or primary example. Instead of increasing calcium levels, these drugs make the heart more sensitive to calcium that's already there, especially at the level of troponin C. This helps improve contraction without increasing oxygen demand or risking calcium overload. While positive inotropes are powerful, so they must be used carefully. They can increase the heart's oxygen consumption and in some cases may trigger arrhythmias, especially with prolonged use or in patients with ischemic heart disease. Now let's talk about the negative inotropic agents. These are drugs that decrease the force of contraction of the heart. They are not harmful by default. In fact, they are extremely useful in certain cardiovascular conditions where reducing the workload of the heart is beneficial. They are commonly used in hypertension, where reducing cardiac output lowers the blood pressure, angina, to reduce oxygen demand and prevent ischemia, certain heart arrhythmias, like especially when driven by high sympathetic tone, and in hypertrophic cardiomyopathy, where reducing contractility can relieve obstruction. Let's go through the major classes. First, beta blockers. Examples include propranolol, metoprolol, and atenolol. They block beta adrenergic receptors, leading to reduced cyclic AMP levels and less calcium entry into the cells. This causes a decrease in both contractility and heart rate, reducing the heart's oxygen demand. Second is calcium channel blockers, non-dihydro pyridines. Drugs like verapamil and diltiazem block L-type calcium channels, limiting calcium influx during the action potential. This decreases cardiac contractility and helps control heart rate, especially in supraventricular arrhythmias. Now, third classification, class 1 antiarrhythmic agents. This includes quinidine and procainamide. They work by blocking sodium channels, slowing conduction, and indirectly reducing the contractile strength. However, they must be used with caution as they can have pro-arrhythmic effects in some patients. Other drugs with negative inotropic effects, some anesthetics like propofol and chemotherapeutics like doxorubicin may cause myocardial depression as a side effect, reducing contractility and potentially leading to cardiogenic or cardiac complications if not monitored. So, while negative inotropes can be helpful, too much suppression of the heart's contractility can cause heart failure, bradycardia, or even low blood pressure. So, dosing and monitoring are critical. Now let's talk about when and why we actually use inotropic drugs and what we need to be cautious about when using them. So these drugs become especially important in situations where the heart is struggling to pump effectively and we need to boost the cardiac output to maintain the adequate blood flow and organ perfusion. So where they are most useful in acute heart failure or in sudden severe heart failure where the heart just is not pumping enough blood, we use positive inotropes like dobutamine, milrinone, or digoxin. They help the heart contract more strongly, buying us time to stabilize the patient. Second, cardiogenic shock. This is a critical condition where the heart's pumping function is so poor that the vital organs start getting underperfused. Here, inotropes can literally be life saving, helping restore circulations. Often, they are used alongside vasopressors to both improve contraction and maintain the blood pressure. Third is decompensated heart failure. In patients with worsening chronic heart failure, inotropes are sometimes used temporarily just to relieve fluid overload, ease symptoms, and stabilize the condition until other treatments can take effect. So, fourth use is after cardiac surgery. Right after certain heart surgeries, the heart muscle might need some extra help to pump properly. So, inotropes can support the heart during the recovery period. Fifth, pharmacological stress testing. And in patients who cannot do exercise based stress tests, we often use dobutamine to mimic the effect of physical exertion during the echocardiography. Now, while inotropes can be incredibly useful, there are also some important precautions you need to understand. First, tachyphylaxis or tachyphylaxis. This just means the body starts to get used to the drug, especially with drugs like dobutamine. Over time, the same dose produces less of an effect, so it becomes less effective if used continuously. Next, oxygen demand. Remember, if you make the heart work harder, it also uses more oxygen. That can be risky, especially in patients with coronary artery disease because it can worsen ischemia. Arrhythmia risk. Many inotropes like beta agonists, PDE3 inhibitors, or even digoxin can disturb the heart's rhythm. In a vulnerable heart, this can lead to dangerous arrhythmias, sometimes even fatal. Long term use not ideal in chronic heart failure. Using inotropes over the long term has been linked to higher mortality rates. So these drugs are usually reserved for short term use or in end stage cases where symptom relief becomes the more focus. Monitoring is critical. Anyone on inotropes should be closely monitored. That includes checking ECG, blood pressure, electrolyte levels, and kidney functions. Because small changes can turn into big problems if you are not watching carefully. All right, let's wrap up. Today we explored the inotropic effect, how the heart's contractile strength is regulated, enhanced, or suppressed using various mechanisms and drugs. We discussed the cellular basis involving calcium handling, positive inotropes like dobutamine, milrinone, and digoxin, negative inotropes like beta blockers and calcium channel blockers, and the clinical uses and risk of inotropic therapy in real world cardiac care. So, understanding inotropy is essential for managing heart failure, shock, and many critical cardiac conditions. If you found this lecture helpful, please support this free educational channel by liking, sharing, and subscribing. Your support truly helps me continue producing high quality simplified medical content completely free. Thanks for watching and see you in the next lecture.